Dr. Davidson, what are your plans professionally for yourself and your plans for your family currently?
Well, I've resigned my position, kind of at the tail end now of a long and awkward process of resigning, but my wife and our youngest daughter and I are moving out of Nova Scotia.
Why is that, Dr. Davidson?
We're moving because, to put it simply, we're moving because of the public health response to the COVID pandemic. Early point before we're doctors, the very early point in medical school and all through medical school, principles of medical ethics are strongly emphasized. And not only that, but they come up every day and with every patient to a certain extent. So I also don't have a PhD in philosophy, but I would say that I'm very knowledgeable about the basic premises of medical ethics.
Can you talk about the concept of informed consent as it applies to the practice of medicine?
Yeah, informed consent is a major cornerstone of medical ethics, and I don't know, maybe it's more obvious to some than others, but obviously it is a principle that we never, as doctors, ever force a medical intervention on someone. History is replete with examples of times where doctors have done that, and those very sad episodes in history are sort of in the background as we talk about consent. Consent needs to be free of coercion and informed in order to mean anything.
And does that principle apply to all medical interventions in Canada?
Does it apply? Historically it would have applied, I would say. And one would think, and I think we all would have said before the pandemic, that the threshold for even considering countervening the ethic of informed consent should be extremely high.
As we entered the pandemic in early 2020, what was your understanding of the danger posed to public health in this province by COVID-19?
Well, I was as concerned as anybody else about COVID-19. Similar to Dr. Lavranis's testimony, in early 2020, nobody knew much of anything about this virus, except that it was really serious and that it could be a catastrophe. So I was very concerned about it. I took it very seriously. Started to work with other doctors in our hospital. Again, a lot of this will sound familiar from Eris's testimony, but in trying to learn as much as we could about it with the limited information that we had at the time, and then trying to prepare for these waves of critically ill COVID patients that surely were going to be coming to our door. So that took up, that concern and fear took up, and trying to prepare, many months going through the summer for sure.
Okay, I'm going to touch on something you just said, or perhaps we can expand on it. So you indicated that you're very concerned, like many people were, during the early stages of the pandemic. What was your observation during the early stages of the pandemic regarding the allocation of in-hospital resources?
Well, I think we were all very concerned. We didn't have much data, but we were concerned enough early on that we all agreed that we needed to be ready, and that it was probably appropriate to slow the hospital down as much as possible. So one thing that was certainly very prominent in our hospital, which has a relatively big surgery department, is that elective surgeries were halted for months. So elective means surgeries that aren't urgent were just deferred, put on hold, and not done.
Now, when you say surgeries that were not urgent, is that the same as surgeries that were not important, or are those two different things?
Yeah, certainly two different things, yeah.
So could an elective surgery still be an important surgery?
Oh, for sure, yes. Yeah. no surgeon should be doing any surgery they don't think is an important surgery to do.
Okay. So you've discussed the allocation of in-hospital resources. Shift gears a little bit. What were your observations in hospital with respect to COVID-related illness during the initial stages of the pandemic?
Yeah, again, and similar to what Eris was saying, we were geared up and spun up. We were getting ready. I was part of sort of teams of people where we were trying to develop these protocols about how we would safely intubate patients in respiratory distress and safely get them to the ICU. Including the possibility of emergency surgical airways if that was going to be needed. Really, certainly in the early months, there was very little of that. Very few, very small numbers of critically ill COVID patients at first. It's hard for me to kind of remember the exact timeline, but certainly for the first several months, there was a lot more sort of preparing than there was actually looking after critically ill COVID patients.
And I think you just referenced critically ill COVID patients. How about during the initial months of the pandemic, COVID admissions generally?
I wouldn't have been involved. I would only be involved if they were ICU patients. Okay. So there probably were some. My impression was that, again, for several months, it wasn't nearly the numbers that we feared that it would be, even the less sick.
Okay. So you had spoken earlier about your significant apprehensions at the front end of the pandemic. Did your level of apprehension or your areas of concern evolve over time? And if so, how and why did they evolve?
Well, certainly. I mean, as you know, with many other people, as the spring turned into the fall, we had more data, and it became evident pretty quickly that the virus was serious, and it could be very serious for certain people. But we were getting a very clear picture of who was most at risk, and as we've heard, age was the major factor for that. Comorbidities such as obesity and diabetes played a role as well, but age was certainly the major risk factor. And I feel like that was becoming very clear, certainly as 2020 turned into 2021. So I was becoming, I guess, less concerned that the virus was going to be a world catastrophe. Still taking it seriously, but less concerned about that.
And where you're talking about age being a significant factor, is that the idea that Dr. Milburn and Dr. Lavranos described as age stratification of risk as it relates to COVID-19? Is that the concept?
Yes, exactly. Yeah, this the concept that if you're a healthy child, I mean, there's no such thing as zero in medicine, but if you're a healthy child, your risk of a bad outcome from COVID approaches zero. If you're 80 years old, you're at much higher risk, like 1,000-fold risk.
Okay. What's your understanding of the risk for a healthy adult, somebody who wouldn't be medically classified as elderly, if that's an appropriate classification?
Again, I mean, by now there's very good data, even on a decade by decade basis. It'd be hard for me to give you a number, but for the average healthy 40-year-old, you're still, your case fatality, certainly your infection fatality number is low, less than 1%.
Is that 1% relative to infections or 1% relative to the population?
Certainly IFR, infection fatality rate. Even the case fatality rate would probably be about that. I don't want to overstate it. But.
Sure. Okay, so I believe that you said a few moments ago that the risk posed to children is close to zero. Did I hear you correctly?
Yep.
Okay. In light of that perspective, what was your sense of locking down schools or locking down society generally?
Well, yeah, that was my first major crisis moment, I would say. So Like everybody else, or most people, I understood and probably even supported the idea of 2 weeks to flatten the curve. But even then, and certainly as that became 2 months to flatten the curve and extended longer, I was increasingly distressed about the idea of wide society lockdowns. And for all the reasons that I'm sure, even at that time, let alone now, would be obvious to everybody in this room, and it boggled my mind why public health wasn't discussing the potential dangers, not potential dangers, the dangers of wide society lockdowns in terms of rationalizing why they were recommending that. You know, the downsides are obvious, and you know, again, Eris talked about this, you've heard it before, but the missed cancer screening, the missed cancer diagnoses, the patients staying at home and not seeing their family doctor to manage their diabetes and their blood pressure, all of the strict health downsides should have been obvious. And then the society downsides, you know, children not going to school, not getting the development that they get from going to school. You know, people, older people dying alone and away from their loved ones. Again, it was obvious to me, and I have no special insight into this sort of thing. I know it was obvious to many people why it wasn't being publicly discussed. It was very distressing to me, and why month after month it was decided that this one virus, which was now just one more way among 1,000 other ways that we could die in life, why that one virus was the only thing that public health was concerned with. I just didn't understand that at all, and it really distressed me.
In your professional medical opinion, was there any medical or scientific evidence that you were aware of during that time that suggested that these ongoing lockdowns should have been or remained implemented?
Not on an ongoing basis. You know, again, we were getting more and more data about who was at risk and who wasn't. The downsides of lockdowns, if they weren't obvious before, I think were becoming more evident. So certainly not on an ongoing basis. There were, you know, preeminent, very prominent PhD epidemiologists from Harvard, Oxford, Stanford, who took a step to organize and gather other preeminent PhDs and other researchers and scientists from around the world to suggest that wide society lockdowns were a bad idea. And they based this on very old planning, that before COVID, somewhat further back in time, the approach to pandemics, it had been agreed, would be focused protection of those at most risk. It was only with COVID that was actually this new idea that you had to shut down the entire society because of this one virus. And their ideas made a lot of sense to me. I didn't understand why they were being demonized in the public and you know, among this new public health establishment and in the media. And then as time wore on, we had glimpses into what other jurisdictions were doing. Countries like Sweden, states like Florida and Texas were not widely shutting down, or you know, they were undertaking more humane versions of that, again, more focused and shorter lockdowns. And their age-adjusted mortalities were no worse. In some cases, they were better than areas like New York or California that were, or Nova Scotia, at least later on, that were undertaking these draconian lockdowns.
Were you aware of any debate or discussion happening within either in hospital amongst your colleagues and leadership, or in the public health sphere in Nova Scotia regarding whether these ongoing lockdowns were appropriate? Was it a matter of discussion and debate that you were aware of?
Not, well, as I said, I was actually very disappointed that it wasn't a matter of public debate, and it wasn't even anything that public health was bringing up, which I would have thought would have been public health's job. So certainly not at that level. In terms of otherwise, I mean, other than me just grumbling and complaining and others sort of agreeing, my colleagues around me sort of agreeing that there would be downsides, there really wasn't a lot of discussion about it. Not nearly enough, in my opinion.
So as time wore on, you've just discussed your views on the lockdowns. As time wore on, did your concerns begin to evolve, or did you have other concerns?
Well, I had other concerns. Elective surgeries don't apply so much to vascular surgery. A lot of what we do is more, is life or limb threatening more immediately, if not emergently. So, I was still operating. I still had my practice, was continuing. And then in addition to all that, I was trying to help prepare and trying to learn more about COVID. So I was very busy. I carried on. I hoped that public health knew what they were doing in terms of the lockdowns, but as time went on, I was just more and more suspicious of that. And I'm not sure if that answers your question or not, but
No.
That's how that evolved.
Absolutely. How about, based on your education, training, and experience, and your understanding of clinical literature, how did you feel about the vaccine rollout and or the implementation of vaccine mandates?
Yeah, so that was the next point of concern for me. So when the vaccines were being developed, I remember being somewhat concerned at the speed at which it was happening. As you've heard, it would normally take multiple years, 5 years, 10 years minimum to get a vaccine to the point of new pathogen to public rollout. The Donald Trump's administration authorized the Operation Warp Speed, and the whole idea of that was that there weren't going to be these normal regulatory processes. They were going to cut the red tape so that these vaccines could be developed more quickly, which is great if everything goes well, but that means by definition you don't have the long-term data, especially in terms of safety. So I had some concern about that. The randomized trials came out, and to be honest, again, I was busy. I scanned them. I didn't read them. In retrospect, I did not read them critically enough, but they seemed to be saying good things about the mRNA vaccines. And then public health obviously was all in. They were immediately safe and effective. It was amazing the confidence with which they could tell us that these were safe and effective vaccines based on 2 randomized trials and a couple of months of data. But again, I was busy and I was naive. I should have questioned things more at that time, but I hoped that the powers that be knew what they were doing in terms of pushing these vaccines. So I myself got vaccinated. I got the 2 primary vaccinations, mRNA vaccinations, in early 2021. Yeah.
Just going to ask you one question about what you said. You talked about cutting the red tape and pushing the vaccines out, and you mentioned 2 months of data, trial data. With your experience as a physician and a surgeon, and you also indicated I should have read the studies more carefully, based on your experience and where we are today, do you believe that was a responsible statement, a medically responsible statement, or a socially responsible statement to characterize those interventions as safe and effective?
No, I don't think. I think that's an irresponsible way to describe almost any medical intervention, let alone a brand new technology that had been studied in 2 randomized trials with a couple of months of data. We never talk about medical interventions like that. I never sit down with a patient who has a problem, and I have a surgery that maybe could fix that problem. I hope it would. I think it will. I never just sit down with them or stand up with them and say, "This is safe and effective. Do it." That's never how we talk about things as doctors, ever. You talk to the patient about what's happening with them, what their options are, and maybe even I give a recommendation, but I also talk to them about the risks of what I'm proposing and the potential benefits, and it's always up to the patient. And if the patient decides against what I'm recommending, you stick with them and you try something else. You never just say, this is safe and effective, do this, take this. It's never how we talk about medical interventions.
Well, and thank you for that, Doctor. A logical corollary to what you've just said is, or the next logical question then, given what you've just expressed to the Commission, how did you feel about the mandates themselves when the vaccines actually became mandated in this province?
Well, so that was the next issue. It's one thing to heavily promote a medical intervention like that to the public, and there's arguments to be made certainly that shouldn't have happened. To then force people to take that intervention is a whole new level, and I really couldn't comprehend that the discussion was even being undertaken. By then, we had even more data about what was happening with the virus, and it was serious. The virus was serious. I'm not a COVID denier. I eventually, later on, helped look after extremely sick patients in the ICU who had COVID. So I don't deny that for a relatively small number of people, it is a very serious disease and it can cause death. There was no doubt about that. But again, by then we had much more data about who was at risk and who wasn't. We had much more data about the magnitude of mortality that COVID was bringing us. And even at that point that mandates were being discussed, we were starting to get data about how the vaccines did little or nothing to reduce transmission of the disease. So, as Eris was saying earlier, in order to even contemplate a mandate where you're forcing someone to take a medical intervention on pain of losing their job or their being able to participate in society as they normally would, in order to even think about that, it would have to be an infectious disease situation where the pathogen is so serious and the intervention is so safe and so effective that you can then contravene this extremely important ethic of informed and free consent. So at that point, it did not seem that any of those criteria were being met. The data was becoming more clear to the extent that it was being admitted on American national television by the CDC and Anthony Fauci that the vaccines were, first of all, losing their effectiveness even in contracting COVID fairly early. Within 4 or 5 months, we all saw the 95% effective go down to 50% effective over the next few months. But more importantly, they were admitting that they did little or nothing to reduce transmission of the virus. And so then, in my mind, and I challenge anybody to tell me how this cannot be, the whole argument for even considering forcing vaccination on someone is null and void.